Thank you very much. It's like a family get-together, so I'm gonna be very short. This is my short introduction of all my family. And actually, I have done like around 7,000 annual cases by myself. So still, I'm doing around 500 cases I'm handling by myself. And because the medical strike, the number is a little bit down, but still I do a lot of treatment. And around then, even though we do have a lot of intervention, but still, I do about 30% I do clipping. So when I met Alex Bernstein, he's my mentor. He asked me, "Do you still correct the skull?" Yes, I do. With after all the evidence, I'm still correct the skull. Why? So because many patients came to me after being recommended clipping at the hospital. So many of them, I do observe, but I prefer to clip, especially in most MCA, anterior inferior ACOM and anterior coronary artery aneurysm. Why? I do respect the ISA study, but we are pushing too much toward neuro intervention. Still, there are beauty of any treatment as a surgically, and wise decision making is the most important factor to lead better outcome. So this is an exact example, MCA. So why we should put the stent? Why we should give the patient aspirin products with a simple aneurysm? On your right side, I think we don't use a lot of interventional technique with a simple the aneurysm. They would put many balloon, many stent. So sometimes as a surgeon, we see the different aspect. So the beauty of Atlas stent, I always mention during the presentation, what is the beauty of the Atlas stent? The beauty of Atlas, we are not able to see through the angiography. When you see the ultrasound during the surgery, it's really scary me. So sometimes the steroid is a little bit outside of the vessel. So I just go back to my presentation. Complex aneurysm will be, as Dr. Poon mentioned, many different categories. As a hybrid neurosurgeon, this is like 7 aneurysms. Initially presented several hemorrhage. So I went to the surgery. Looks like ACOM has been ruptured. So I clipped the 4 aneurysms simultaneously. And then I bring the patient back for a second intervention. I did treat the 3 other annual neurointerventional way was published in Neurosurgery in 2011. And BBA aneurysm is one of the most difficult aneurysm to treat. So I did publish 2006 about all my surgical experience. And surgical, according to my paper, surgical experience has been changed from clipping. And then actually clipping was not the right answer and moved to the surgical trapping with bypass surgery, and the patient suffer early vasospasm. So we tried to save the parent artery. We didn't use clipping and wrapping with or with a bypass surgery. So there was some evolution of the surgery. But since 2006, I stopped doing the surgery. Then I moved to neurointerventional way. This is my typical way to treat. So we can get the very loosely packed annulus with a multiple overlapped stent. So the purpose of this, technique is we can prevent ultra early bleeding, and we can get the flow diversion effect. Now we do have a flow diversion error. So now, once you have a blood blister annulus, we do have another tool for flow diversion. So, Daddy, I have a blood blister. Okay, we have a flow diverter, but it's not the always the right answer. This is a recent case. Initially, this is a recent my strategy. So once we have a blood blister annulus, I do apply the center scoring because, for the rupture case in Korea, we are not able to get the reimbursement flow diverter at the initial stage. So I did use center scoring. But we know that this been definitely coming back to ultra early recurrence. So before the patient discharged from the hospital, we bring the patient back for the angiography follow-up. As I expected, there is a recurrence. Then I did put the flow diverter. This is final one. This is 2 weeks after, so we can get a very good occlusion like this one. V dissection, this is also difficult aneurysm to treat. This patient came to me like early in the morning, 4 o'clock in the morning, with a poor subarachnoid hemorrhage. This is a monster, so actually there's a huge giant aneurysm and vertebral vaginal aneurysm, and with the ICA is coming off the shoulder. And actually we do have a lot of options, but I did choose the vertebral artery, bilateral vertebral occlusion, because this patient is very distant control the right side PCAM. And this 3 weeks, 7 weeks, this is 4 months. The patient completely recovered, has been followed more than 12 years. So I did published all my series with the Journal of Neurointerventional Surgery about all the different, the approach of the vaginal junction joint aneurysms. This is another VA dissecting aneurysm. So I did publish with PICA VA standing first time in the world. And this is the first case of vertebral artery and PICA intervention. And this is 7-year follow-up we are able to save. And this is, I did publish an AJNR with all the series. So, and also, what if the patient actually the PICA is incorporated with present with a ruptured case? So, as you know about the blood breast aneurysm, I do use a conventional technique like standard scrolling, and I did pretty good. But I was I was able to prevent the ultra early rebleeding, but definitely this patient coming back for recurrence. This is 6 months follow-up. As I expected, there's another recurrence. So I decided to put the flow diverter like this. This is our common strategy when I dealing with a blood breast aneurysm with dissection aneurysm. This is a 10 months follow-up. Okay, difficult location. This morning, Dr. Jungman, beautifully presented the web experience, but I reserved the web for a special indication. This is actually the patient is 74, is a ugly shaped basilar top aneurysm with a BA, very, very stenotic area. So we are not able to treat with the conventional technique with the standard scoring, but it's very atherosclerosis. So I did put the web. So it was a very nice indication. So this is 8 months follow. This is another case, myxomatous aneurysm, MC, very, very dirty myxomatous aneurysm. So we are not able to treat with conventional, with the medication, the patient coming back for the recurrence. And what I did was we can go to the surgery, we can, apply for the clipping for the very dirty aneurysm. And definitely this patient definitely coming back to the recurrence. Then this is a 1-year follow-up, still aneurysms keep growing. Then what we did is we put the bypass surgery from STA at MC bypass surgery in occlude parent artery. And this is pretty good, but the 6 months follow-up, the patient coming back for the, another recurrence, we did put the stensis according for this case. So with surgical technique, with interventional technique, we can get a very optimal result like this one. So giant aneurysm, definitely, that's beauty of the flow diverter. This is, I just try to present 2 beautiful cases for all my flow diverter experience, more than 300 cases. This is, initially the patient was falling tendons with brainstem compression. And I was very lucky. At that time, we have a pipeline, and it was more than 13 years ago. I just put the flow diverter, keep my fingers crossed. And very, very luckily, all the propeller has been saved, and the aim has gone. This is a 2-year follow-up, this 4-year follow-up. This patient followed more than 10 years without any neurological deficit. Thanks to the flow diverter, we are able to treat this monster. This is 13 years follow in my clinic. This is another beautiful flow diverter, MCA fused aneurysm. Actually, in this area, we are not able to treat the bypass surgery. If you do the bypass surgery trap, so actually the patient ended with a lenticular infarction, even though you did the surgery very well, and the patient ended with a right side weakness. And flow diverter, I don't think we can get the 100% very nice result with this kind of monster, but this is a 3 months follow-up. There's some filling of aneurysm. The filling is not just any filling. The filling is to irrigate the supply for the lenticular striatum, which was not visible at the initial angiography. But this is a 1-year follow-up. This is a unbelievable result. So we can see the lenticular striatum was reconstructed through the stroke of the flow diverter. But there's some drawback of the flow diverter, delayed annual rupture, and worse than mass effect. Actually, this patient initially treated other hospital standard scoring, and there is another recurrence. The patient came to me get another second treatment. So we did treat the flow diverter, but the patients keep growing, and we put another flow diverter, still keep growing. So once this kind of monster start to grow, there's no other way to stop this growing without any definite treatment to surgery like this one. Sometimes, how do I treat a very large giant aneurysm? Sometimes the patient is massive. I still doing the surgery. Surgery is very straightforward. It's not easy. It needs experience, but this is a formal treatment. Otherwise, one of the best treatment you have to do like all the collateral study, and if you are able to, so actually proximal occlusion is one of the best option to treat, and also you can go for the STMC bypass with insurance. So this is pretty good. Still, with we are living in intervention era, but still, proximal occlusion, total arterial occlusion, the best option to treat this kind of monster. Recurrent aneurysm, yes, this is also one of most headache case. 2 times treated with interventional way, and the patient is keep coming and increased mass effect. The patient presented with a visual disturbance, and actually this is a final angiography. The angiography is a giant annulus with a mass effect. So we have to take to reduce mass, we have to take all the mass out. So this is the final one. So we can save the patient, we can save the vision. And also, this is the beauty of surgery. So surgery was good, but actually, even though, with good hand, we did complete occlusion of surgery at the aneurysm, but the patient coming back for the cerebral hemorrhage, then, so advent of the neurointervention with the stethoscope, we are able to treat this patient. So trip strategy is almost important for the treatment. Now you're good for the surgery intervention, but you don't need to do both very good. But your team, if we are able to provide the best treatment option, so we can get the optimal outcome. So this is my purpose to be here. So I'm very proud to announce I'm hosting 2026 WF15 in Korea. Please mark your calendar, October 11th to 15th. So actually, we are expecting more than 2,000 physician attendees in Korea. So it's going to make a history for WF18 history. Actually, this is a video, but you have seen, but okay, just 1 minute video. Busan is not like Hong Kong, but we do have a nice beach. Better than Hong Kong, better than Nice, better than any other country. So I think you have to come to Korea and enjoy the Korean atmosphere, and also to enjoy the vibrant atmosphere of Busan as well. So actually, we subscription open was absolutely open was already opened from this month, and actually still plenty of time. So you should come. And also, I'm very proudly to announce, so we are able to provide some grant for the country from some middle or low income country and young physicians. Actually, with the help of Hyundai Motor Company, we are able to provide 100 physician education grant to those coming from some countries. Thank you very much for your listening. Thank you very much.